March?
Yes.
All right. Long COVID. Your statement makes plain that from an early stage you asked NHS England to consider what could be done, and you asked Simon Stevens to develop plans for addressing the issue of long COVID. From your assistance to the promulgation of NHSE guidance in June and the announcement in July by the National Institute for Health Research and UK Research and Innovation, and also your convening of a roundtable in July, it appears very clear that you were alive to the concerns about long-term sequelae from the infection.
I was alive to it from before the infection reached our shores. Chris Whitty raised the concern about the potential of some kind of post-viral fatigue syndrome, which happens with other viruses as well. And then after the first peak, I was acutely aware of it, not least because members of my family were affected by long COVID, including my mother, who still attends a long COVID clinic. So this was very close to my heart.
To what extent, when you and your colleagues became aware of long-term sequelae and the long-term consequences of infection, did that understanding feed its way into the debate about the mechanics of non-pharmaceutical interventions and then subsequently the relaxation of restrictions? What role did, or to what extent did the issue of long COVID play out in the debate about the mechanics of NPIs?
Well, it matters, of course, because it makes the virus even worse. It makes the impact of the virus even worse. And so it reinforced the arguments that we were making already. Of course, the best way to avoid long COVID is to take the measures necessary to reduce the amount of COVID, full stop. And so it actually calls for the same policy prescription in terms of preventing COVID and therefore tough NPIs to keep R below 1. But it also required more research and support from the NHS, who found it quite difficult because it was a new disease and because of its nature presenting in many, many different ways. They found long COVID quite difficult to categorise at first. And so with Simon Stevens, we worked together to bring forward long COVID clinics that could look across the range of conditions that are loosely gathered under the term long COVID. As I say, I cared a lot about this for personal reasons as well as professional reasons, and we didn't need sign-off from the centre. We just got on with it. As I say, I cared a lot about this for personal reasons as well as professional reasons, and we didn't need sign-off from the centre. We just got on with it.
Do you happen to know why, notwithstanding the considerable amount of work done on long COVID from the very early days and throughout the summer, particularly of 2020, the public campaign about long COVID wasn't launched until I think October? Do you know why there was that potential lag in the communication side of the debate?
Yes, I think it was essentially because understandably the clinicians found it hard to get a handle on exactly what the term meant at first. I knew what it meant, and those suffering from it knew what it meant. But turning that into a formal protocol would normally have taken a lot longer, but it was one of those things that happened. It took some months for the clinicians to put it together. I think we decided to do that was it June or July 2020, at that roundtable meeting that you mentioned.
The 31st of July, yes.
31st of July, which I'd convened. And so it was put together in around 6 weeks from then. So although that looks slow in the context of the pandemic, that is fast in the normal context of medical response to innovative problems.
Particularly the public-facing side of the medical response.
Yes, and you know, clinicians understandably wanted an answer to the question, what exactly is long COVID, before they would go out and say that we're having a campaign on this. So that was it was a piece of work. Of course, I wish it had gone faster, and I was pushing it. But nevertheless, I can understand the reasons it took as long as it did.
Mr. Hancock, I asked you a small number of questions on two topics on behalf of the long COVID groups. You said that you agreed to put together a campaign on long COVID on the 31st of July 2020 at a round table which resulted in the public campaign launched in October 2020. This agreement came after long COVID SOS wrote to you in July 2020 saying they were struggling to get help from the medical community for their disease and felt abandoned by the government. In the interim, Long COVID Support raised similar concerns with Jeremy Hunt, and you responded to a letter they wrote in September 2020. And in October 2020, Long COVID Kids also raised additional concerns in relation to long COVID in children in a public letter to the British Medical Journal. In January 2021, Long COVID Support wrote a letter to all members of Parliament still asking that long COVID be made of the narrative. We know, and you've said, that DHSC issued a press statement and just the one video on long COVID on the 21st of October 2020. One statement, no slogans were created, no public information campaigns were launched, and no further videos or press statements were released. You've said yourself that communications are an important NPI. Why wasn't more done to communicate the risk of long COVID to the public when you had long COVID groups repeatedly raising concern about the lack of communication?
Well, I'm very grateful to you for the work that you've done, the group's done on this. And writing to me in July was important because it made me realise that there was a problem that needed to be addressed, given that I knew about the impact of long COVID personally. And so hence I convened that round table and we took the action that we did. And we discussed earlier why it took 6 weeks from then to October, mid-October, to launch the plan. The only part of your question that I would disagree with is that there was only one comment put out. I repeatedly discussed long COVID on my own, both my own media appearances, my social media, and other areas. But it's absolutely true that it felt like it was an area that I felt I needed to push.
So do you agree and accept that insufficient was done to communicate the risk of long COVID to the public?
Well, I think that raising concerns about long COVID was an important part of explaining why it's important to tackle COVID. The large swathes of the public understood that and were on side for that. The campaign against it was ranged in a relatively small part of the political debate, if you like.
Well, you raised long COVID on your own, but why wasn't it raised across government?
I don't know. You'll have to ask people across government. I mean, I had my shoulders to the wheel on this one.
Can I move on to a sort of connected issue and one that also concerns risk of infection? Can I ask you about your understanding of airborne transmission?
Yes.
What were you advised about this risk, and when did you become aware that it was a significant route of transmission?
So, just to be totally clear, are you asking about the distinction between droplet transmission and airborne transmission through essentially aerosol?
Yes, I am.
So this was a really, really important point and sometimes quite complicated to describe, and also the science behind it was very complicated to ascertain. So how the virus spread from one person to another is obviously an absolutely critical part of transmission, not only the rate of transmission, but how. And early on, based on previous coronaviruses, it was largely assumed that it was droplets that made transmission happen, and therefore not being close to somebody was one of the most important things. But it became clear through the early summer of 2020 that, in fact, airborne transmission was more important. So it was a bit like if you have a... I remember the very first description, which again was given to me by Professor Van Tam in his eloquent way. If you have a smoky candle, the way that the smoke will go in the whole room, the consequence of that is ventilation. What became seen as much more important and is more important for dealing with the transmission of COVID than droplets. But that was not understood at the start because it was a novel disease, and the starting point was an assumption that the transmission was the same as SARS-CoV-1.
Thank you. You spoke at length yesterday about your regrets in relation to asymptomatic transmission. Do you think there are any parallels and lessons to be learned with aerosol transmission? For example, should a more precautionary approach have been taken?
With hindsight, obviously, but I think at the time, the science on this was really was unclear. But I do think, to your point, a lesson for the future is that when you have a disease that spreads without necessarily person-to-person touch, then you should immediately assume that good ventilation should be part of your infection control procedures.
Thank you.